So this is our topic of Figo staging of endometrial cancer, and these will be the contents we will be studying. So with introduction, endometrial cancer is most invasive cancer of female genital tract and is also the sixth commonest cancer in the woman worldwide. The peak incidence is seen in the age group to 55 to 65 elderly. So, despite advances in clinical research, the endometrial cancer incidence and mortality are worsening. So, very sad news for us, but this is how things are happening. So, with the corpus malignancy, we have seen more than 1%, it increasing every year, and also 2% in younger women. To focus up to date diagnosis, staging, and management, International Federation of Gynecological and Obstetrics, also known as Figo, has established staging system which is gradually revised based on the latest clinical evidences. So WHO is another and the Figo one is different. Figo 2023 staging system has been revised from Figo 2009. So you can see how much difference has been taken, right? So the goal of the new staging systems is better define these prognostic groups and to create subtypes to indicate more appropriate surgical radiation and systemic therapy. So with this, we'll get to know how the prognosis will be if we do the surgery, the radiation, or systemic therapies. Coming to next. So FIGO staging. The main FIGO staging that you need to remember is stage 1, which is carcinoma confined within the uterine body. So this is our stage 1. So the cancer is present only within the uterine body. With the stage 2, carcinoma may extend to cervix but is not beyond the uterus. So it is spreading towards the cervix but not going beyond the uterus. With stage 3, we'll see the extension beyond the uterus but confined to the pelvis. So we can see the vaginal invasion is present, in lymph node, inguinal lymph nodes may be getting involved, but it is confined within the pelvic region. So, with the stage 4, the carcinoma involves bladder, bowel, and has metastasis to distant sites. So, liver is getting affected, or bowel into bladder. According to this, we are stating the stage 4 to 4A and 4B. And now, this is the WHO classification of tumors of uterine corpus. So, as you can see, this is a quite big classification presenting here. So we are studying here the endometrial epithelial tumors and precursors. So within this, we can know that the tumors involving in endometrial epithelial region are endometrial hyperplasia without atypia, then atypical hyperplasia of endometrium, and endometrioid adenocarcinoma of not specific and pole ultramutated endometrial carcinoma, mismatch repair, deficient endometrioid carcinoma, P53 mutation endometrial carcinoma, no specific molecular profile endometrioid carcinoma. And with another stage, serous carcinoma of not otherwise specific and clear cell adenocarcinoma, no otherwise specific, and carcinoma undifferentiated nose, mixed cell adenocarcinoma, mesonephric adenocarcinoma, squamous cell carcinoma, mucinous carcinoma, intestinal type, and we also have mesonephric like adenocarcinoma and carcinosarcomas. So these are our tumor classification of endometrial epithelial tumor and precursors. The subtypes of endometrial carcinoma that we need to know are type 1 tumor, about 80%, endometrioid endometrial carcinoma. So these are preceded by endometrial hyperplasia or EIN and are associated with estrogenic stimulation. So they occur mainly in pre and perimenopausal women and are associated with obesity, hyperlipidemia, anovulation, infertility, and late menopause. Tumor in category are typically low grade and prognosis is favorable. And the type 2, which are about 10%, these are non-endometrioid, and largely serous carcinoma arising occasionally in endometrial polyps or from precancerous lesions like in atrophic endometrial intraepithelial carcinoma. So they are not associated with estrogen stimulation, not or hyperplasia, and readily invades myometrium and vascular spaces. That is why I have worse prognosis. They also include rarest clear cell carcinoma and carcinosarcomas. So the lesser one are the rare one, and the rare one are the worse one. Endometrioid adenocarcinoma. Here, the type 1 endometrial adenocarcinoma presents as fungating mass in the fundus of uterus. And you can see here, this is a fungatus fungus-like protrusion that is spreading across the uterus. And here, you can see these parts, these small, tiny tumors. So this is how it is occurring. So endometrioid adenocarcinoma with histopathologically we can see well differentiated grade 1 endometrioid carcinoma with preserved glandular architecture. The glands are clearly preserved. We can see the clear architecture here clearly and lack of invasion to the stroma. You see stroma is not getting invaded. All the boundaries are very clearly defined. The next, endometrioid adenocarcinoma. Here we can see moderately differentiated grade 2 endometrioid adenocarcinoma with glandular architecture and mixed with solid area. So here you can see the glandular island are mixing to each other. Here these are somehow becoming difficult to define the boundaries within the stroma also. So this is how it is moderately differentiated. And then the poorly differentiated grade 3. Here we cannot define where is the stroma, where is the glandular uh, boundaries. So it is very difficult to define in between. So endometrioid adenocarcinoma with predominantly solid growth pattern. So morphologic variant of endometrioid carcinoma. Here we can see veloglandular pattern. So this is the veloglandular pattern. Just combining with each other. Here you can see villus gland like pattern. Then adenocarcinoma with squamous differentiation. Here we can see squamous differentiation, formerly known as adenoacanthoma if low grade and adenosquamous carcinoma if high grade. So refers to endometrioid adenocarcinoma containing squamous elements derived from metaplasia of tumor gland. So here you can see the presentation, right? So now choroid or hyalinized endometrioid carcinoma. In this, it is characterized by epithelial cell in coats separated by hyalinized stroma. Spindled epithelial cells are also commonly encountered. The nuclei are grade 1 or 2, which serves to separate these low-grade variant of endometrioid carcinoma with carcinosarcoma, with which they are often confused. So, spindled epithelial cells are commonly encountered here. If I was able to zoom this for you, I would have been able to explain it better. So the nuclei grades are one or two. It serves better to separate low grade variant from high grade. Microcytic, elongated and fragmented. Melt pattern. So here we can see it is characterized by small pockets of fibromyxoid stromal reaction that contains varying pattern of admixing eosinophilic carcinoma cells, small glands with attenuated epithelium like microcytids, uh, elongated glands with a flattened lining mimicking the endothelial cells or cluster of detached cells or individual cells. Lymphovascular invasion in the myometrium and lymph node metastases are commonly identified. So in microscopy, as you can see here, secretory carcinoma. So here the secretory phase of endometrium, you can see secretory characterized by neoplastic glands having subnuclear vacuolation. So these are the vacuolation presenting here, subnuclear vacuolations resembling normal 17-day secretory endometrium and accompanied by late secretory pattern in the adjacent non-involved endometrium. This tumor is believed to be expression of pattern that may be present diffusely or focally in a well-differentiated endometrioid carcinoma, usually as a result of progesterone stimulation. Mucinous adenocarcinoma. Here we see uninvolved myometrium. Tumor protrudes into endometrial cavity here, and tumor invades to myometrium here. So, mucinous adenocarcinoma mist consists predominantly of tumor cells showing mucinous differentiation. It is rarest variant of endometrial adenocarcinoma. It is distinguished from atypical mucinous glandular proliferation of the endometrium by increased glandular architecture complexity. In microscopy, it is characterized by abundant intracellular mucin within the tumor cell. Here you can see intracellular mucin. Serous carcinoma. Here we see high-grade estrogen-independent carcinoma of the endometrium, commonly in post-menopausal women. Serous carcinoma is highly aggressive form of endometrial adenocarcinoma and closely resembling tubo-ovarian high-grade serous carcinoma. Often arises in atrophic uteri and may be confined to a polyp, associated with worse prognosis than endometrial carcinoma. In microscopy, we can see serous carcinoma of endometrium with papillary growth pattern consisting of malignant cells with marked cytologic atypia, including high nuclear to cytoplasmic ratio, atypical mitotic figures, and hyperchromasia. Here you can see, plus this papillary growth pattern here, right? This is papillary growth pattern. With immunohistochemistry, the positive stains we find here is P53, which is staining either strong and diffuse, complete absence of staining, null type pattern, or abnormal cytoplasmic localization. P16 is often strong and diffuse. AE1, AE3, and CK7 strong membranous staining. and Paxate strong nuclear staining. With the negative stains we find here is CK20, ER and PR. These are decreased expression, often negative or focally positive in approximately 50% of cases. WT1 may focally positive in 30% of cases. Molecular or cytogenetically we find mutation in TP53 and PIC3CA common. Carcinosarcoma, malignant mixed Mullerian tumor. So it is rare, aggressive neoplasm, occurs in most postmenopausal women and most frequently in uterine corpus. Biphasic tumor with malignant epithelial, more common high-grade carcinoma and sarcomatous. So the grossly we can see is large friable polypoid mass. The tumor fills the entire endometrial cavity, invading deeply into myometrium and extending out through the cycle ovus. Variegated cut surface with hemorrhage and necrosis. Microscopy we can find glandular and mesenchymal component of carcinosarcoma. Immunohistochemistry, we find it carcinomatous component, PAX8, EMA, cytokeratin positive, and sarcomatous component often shows aberrant P53 expression, rhabdomyosarcoma, which is desmin and myogenin, liposarcoma, chondrosarcoma is S100. So, molecular cytogenetically, TP53 frequently mutated and mutation in PIC3CA, P10, and PIC3R1 also common. Now, clear cell carcinoma. Clear cell carcinoma comprises a rare yet aggressive subtype accounting for less than 5% of uterine carcinomas, usually older postmenopausal women, and most clear cell carcinoma are mixture of at least two architecture pattern. The most common form is papillary and solid mixed growth, and it has a worse prognosis. Microscopically, we can see clear cell carcinoma is composed of large clear cells. You can see so many clear cells surrounding. So, with a distinct cellular matrix and containing viable but usually a large amount of glycogen present here. You can see, and the papillary formations and hobnail cells are found in the variant of adenocarcinoma, resemble to those seen in ovarian, cervical, and vaginal tumors. So we can also see hobnail pattern here. So immunohistochemistry for clear cell, we find positive strain are HNF1B, napsin A, EMACR, mismatch repair, expression, CK7 and P53 with the negative stains of ER, PR, CD10 and the molecular cytogenetics we find here is P53 abnormal has worse prognosis and mismatch repair deficient pole mutation have more favorable prognosis. Undifferentiated and differentiated carcinoma we find median age is 55 years. 2% of endometrial carcinomas are presenting this variety. Tumors are often associated with mismatch repair, SW1, SNF, protein deficiency. There is a component of low-grade endometrial carcinoma. It grows in form of solid sheets of cells without any sign of differentiation. And with the microscopy, we can see juxtaposed and differentiated towards the left direction and the undifferentiated component is diffuse without glandular or papillary structure. See papillary, papillary, papillary. The differentiated component here is low-grade endometrioid adenocarcinoma. The immunohistochemistry shows positive stain for differentiated component with CK7, Paxade, ERPR, and E. Catherine, whereas undifferentiated are Ki67, EMA, CK18, Paxade, ERPR may be focally expressed but can be completely absent also. Mixed cell carcinoma is composed of two or more discrete histological types of endometrial carcinoma, where at least one component, either serous or clear cell, is present. The criteria of minimum 10% may be present of the each component to call it a mixed carcinoma. So the prognosis depends on the higher grade component. So here all you can see. So the Figo staging of endometrial carcinoma 2023. Here is the special article showing the updates, and you can read it also on Bille. The histological types we find it in 2023 revision is the tumor is of important prognostic predictor in endometrial carcinoma, and all endometrial carcinoma should be classified according to the fifth edition of WHO classification of tumor and female genital tumors. These subtypes are categorized according to the histopathology, and the classification of the subtype is the predictor of prognosis and is currently involved in revised Figo 2023 staging. Non-aggressive histological types include grade 1 and grade 2 endometrioid carcinoma (EEC), most common type, and aggressive histological type include high-grade EEC, serous carcinoma, clear cell carcinoma, and mixed carcinoma, and differentiated carcinoma, carcinosarcoma, and gastrointestinal type, mesonephric like mucinous carcinoma, as also we read in WHO classification. Importantly, high-grade EEC grade 3 is prognostically, clinically, and molecularly heterogeneous disease, and the tumor type that benefits most from applying molecular classification. And the molecular profiling is of particularly importance and highly recommended in high-grade EEC. So the tumor grades we will study are characterization of histological grade is very important, and initial biopsy curettage and the final hysterectomy specimen, especially in EEC and NSMP, and with the other following mesonephric like gastrointestinal mucinous like type consist of high grade by definition. So these all are clear cell or squamous cell. So these all are of high grade. And for EEC grading is prognostically significant. The grading criteria of EEC are primarily based on the architectural features. So binary approach of WHO classification is endometrial carcinoma, low grade, then high grade, then grade 1, grade 2, grade 3, grade 1 with the 5% or less solid growth pattern, grade 2 5 to 50%, and grade 3 more than 50%. So it is most important to consider the nuclear atypia aggressive, excessive for the grade, raise the grade of grade 1 to 2 by 1. So the nuclear atypia in architecturally low-grade EEC should be taken as an indication to rule out CS grading is especially important to NSPM endometrioid cancers. Myometrial invasion extent of invasion has long been recognized as an essential prognostic risk factor, and it is recommended that the assessment of the percentage of myometrium involved should be expressed as a percentage of overall myometrium thickness infiltrates by carcinoma using the three category none or less than 50% or more than 50%. And lymphovascular space invasion should be assessed at the invasive front of the tumor. So it is crucial to distinguish LVSI from mimickers such as microcytic, elongated, fragmented pattern of myometrial invasion and retraction artifacts that may occur in the setting of minimally invasive surgery. It is very important to distinguish between substantial or extensive LVSI from local to no LVSI. So the criteria is for lymphovascular invasion according to the rules of WHO should fall under this category. Either it is negative, zero vascular involvement, or less than 5 vessel involvement, or more than 5 vessel involvement. So, cervical stromal invasion, we see any invasion of the cervical stroma identified at the level of deeper than the benign endocervical crypt or should consider cervical stromal invasion. The cervical glandular extension is not considered for staging. At an external involvement, we have seen the impact on overall survival. In the case of high-grade tumor, ovarian involvement is always categorized as metastatic. The recent molecular studies have also shown clonal relationship between the endometrial and ovarian tumors, and in vast majority cases suggesting the tumor arises from endometrium and secondary extends to the ovary. So with the revised 2023 Figo staging, endometrial carcinoma endorses this view and established the category of stage 1 E3 when the following criteria are met in the low grade EEC. No more than superficial myometrial invasion is present. The absence of substantial LVSI, the absence of additional metastasis. The ovarian tumor is unilateral and limited to the ovary without capsule or invasion or breach. So, the cases not fulfilling these criteria should be interpreted as extensive spread of endometrial carcinoma to ovary, which is stage 3A1. So, tumor involved of fallopian tube should also be recorded under the stage 3A1. Uterine serosal involvement, here we see it is defined as a tumor reaching some mesothelial fibroconnective tissue or the mesothelial layer, regardless of whether the tumor cells may or may not be present in the serosal surface of uterus. Lymph node status is a most important prognostic factor for endometrial carcinoma. According to TNM-8, micrometastases are larger than 2 mm. Micrometastases are 0.2 to 2 mm in size and more than 200 cells, and isolated tumor cells are up to zero point 0.2 mm in size and up to 200 cells. So, finding of isolated tumor cell does not upstage a carcinoma, and ultrastaging is recommended for the analysis of sentinel lymph nodes. So, this was our 2009 Figo staging system, which has been revised to 2023 Figo staging system. So, again, you can see here the stages are stage 1 to A having the three stages and A 1B and 1C. Whereas the first in 2009 it was only stage 1A and stage 1B. And now stage 1 2 also divided under the three categories, and stage 3 furthermore divided according to the metastasis to various organs. At stage 4 the bladder mucosal and intestinal mucosal and distant metastasis. So the distant is involving the lung, liver, brain, this how. And here the local and regional metastasis with the stage 3 was present. Now it is a comparison for the Spigo staging. You can see with this 2009 and 2023 again. Coming to the molecular classification. So, adding to the molecular subtype or staging of criteria improves the prognosis prediction of the endometrial cancer. So, complete molecular classification, pole mut, MMRD, NSMP, P53 abnormal is recommended for all endometrial cancer cases. The molecular classification aids in the high risk group stratification and influences adjuvant or systemic treatment decisions. So, most impactful molecular classification proposed by Cancer Genome Atlas, which classify endometrial carcinoma in four categories. Whole ultramutated, which is of 12%, then mismatch repair deficient endometrioid carcinoma 40%, and P53 mutant endometrioid carcinoma 18%. So the P53 mutant endometrioid carcinoma has the poorest prognosis, whereas mismatch repair deficient has intermediate prognosis, and the pole ultra mutated 12% have excellent prognosis. So that the least percentage has the excellent, whereas in between the 18 percentage has our poorest prognosis. So non-specific molecular profile endometrioid carcinoma of 80%. It shows the prognosis is intermediate to excellent. So the good prognosis pathogenic pole mutation, and the intermediated one is mismatch repair deficiency or no specific molecular profile, and the poorest is P53 abnormal. So here the Figo endometrial stage with molecular classification we can see. So and its furthermore invasion and lymphovascular invasion we can know through this. This is our take home message. Thank you so much. I'll try to present furthermore more interesting and essential topics furthermore. Thank you.